This Week in Virology, the podcast about viruses, the kind that make you sick. From Microbe TV, this is TWiV, This Week in Virology, episode 1208, recorded on April 10th, 2025. I'm Vincent Racaniello, and you're listening to the podcast all about viruses. Joining me today from New York, Daniel Griffin.
Hello, everyone.
I should know that tie. I recognize it, actually.
It's a very classic one that I wear. I wore for a lot of media appearances during this past.
It's a coronavirus tie.
You got it. Yes.
Very good. Did the media like it?
It's nice because here's this coronavirus. But I hate to tell you, it adds to the conspiracy because I owned this before December 2019. So
you made it in your lab, huh?
Actually, the bow tie was custom cut up in Vermont, so you got to check those.
Hey.
But let's jump right into it. I got to start off with a Paul Farmer quotation. As I mentioned, I recently finished reading the book "Everything is Tuberculosis," which, according to my wife, is still my worldview. And so Paul Farmer started this organization, Partners in Health, with I think it's like the granddaughter of Roald Dahl or something, as well as Dr. Kim. And so here's the quotation: "Statistics or graphs are not optimal to understand the experience of suffering." And I think of this as, a lot of times as science communicators, we focus on these big numbers and these graphs and the statistics. But really, human beings resonate to stories of individual experiences. So I'm going to make sure as we go forward that, not only do I talk about the data, the science, but I also try to connect people, because when we talk about, deaths, we're talking about someone's daughter, someone's sister. We're talking about human beings. So,
Daniel, you have a picture of a suffering baby in these show notes. That gets me.
It does, though, right? You see that
more than any statistic. Yeah, I mean, I don't want any baby to suffer like that. It's horrible.
And I think that's what happens. Like as we get to measles, we'll talk about individual children that have died so far. So we will start off actually with what I thought was some pretty exciting. I'm going to say exciting pro-vaccine news, and this is it appears we may have a vaccine to protect against dementia. Unfortunately, there are some folks that might have benefited from this who are maybe running our government and allocating or not allocating science funding. Did I say that? All right. The article, "A Natural Experiment on the Effect of Herpes Zoster Vaccine on Dementia," was published in Nature. And this didn't come out of the blue. This actually builds on a lot of interesting basic science and some other studies. So we know that certain viruses, neurotropic herpes viruses. So, you think herpes, well, that isn't just herpes 1 and 2, but in that same herpes viridae group, we have chickenpox virus, the varicella zoster virus. And this has been implicated in the development of dementia. And there's a couple ideas. So one idea is that there's an immune response, or the virus itself may trigger the production of tau and other harmful substances in the brain. So here they looked at the effect of, this is, I think, important, the original old-fashioned live attenuated replication competent herpes zoster vaccine on the occurrence of dementia diagnosis. And they took advantage of this really sort of wonderful opportunity to follow this. So these investigators took advantage of the fact that in Wales, eligibility for the zoster vaccine was determined on the basis of an individual's exact date of birth. There's no wiggle room here. So those born before September 2nd, 1933, were ineligible. You're never going to get you don't get the vaccine, and you're going to stay ineligible for life. It's really kind of funny. You're like, I was only born like one day earlier. But so if they're born before that, if I'm only born a little bit later, so those who were born on September 2nd, 1933, or after, were eligible for the vaccine. So because of this policy, basically before this policy went in place, just about no one had been vaccinated. It was 0.01% of the folks had been vaccinated. And then the folks that were eligible and we're looking at just this 1 week, because we're going to compare it to the folks that are 1 week older. About half of them, 47.2%, go ahead and get vaccinated under this program. So really similar groups. The only difference is this 1 week. And there's a great deep dive where they go into like, well, something happened in the schools. Was there a comet past the earth? Like, who knows? Was there anything different between those? And there's really nothing. It's just this 7-day difference in when you were born. And what did they observe? They observed that those folks that received the zoster vaccine had a 20% relative reduction in a new dementia diagnosis over this follow-up of 7 years. They noticed the protective effect was actually stronger among women than men, and there's even some speculation in my mind that, well, only 50% got it. So, could we be seeing a 40% relative reduction if everyone had actually gone ahead with the vaccine? They show this really nice, I like the way they do this probability of at least one shingles diagnosis, because we're seeing two things. One, we're seeing it works, that it does prevent you from getting shingles, but we're also seeing this really nice reduction in dementia diagnosis. So I'm going to leave a link into the TWiV deep dive, but Vincent, you spent a lot of time with this paper. What are you thinking?
Well, first, this is a beautiful study because, it's an observational study. It's a real world study. Except they could rule out all the confounding factors because they have people within a week of each other who didn't get the vaccine or did get it, right? And so there's not likely to be anything confounding, but although they do go through and rule out a lot of things in the paper. There's a really substantial effect, as you mentioned, on reduction of dementia. Now, the only thing I want to know is, this is Zostavax, as you said. It's infectious attenuated. I wonder if it works for Shingrix also. If it has to do with the virus itself, then it should work with another vaccine. That would be nice.
We're actually, the speculation, if they've got the mechanism right here, would be that the Shingrix would work even better, right? Because this is not a great vaccine. And the Shingrix is better. And I think also to go along with the same, they looked at, the subset of people. So you get shingles, right? Certain number of people will get shingles because this is not the best vaccine in the world. And then they looked at people that quickly got on antivirals versus people that didn't get antivirals. And the people that get antivirals had a further reduction in dementia. So, really a lot of suggestion that it's this virus that's somehow triggering a lot of,
I've got my 2 doses of Shingrix, so we can make me part of the study, going forward. We'll just
me too, so we need to.
You can watch us here on TWiV and make your own decisions, right?
See if we end up with dementia or not. So.
Yeah. Who are you again?
All right. So I just taking a sip of my coffee. I always wonder, like when I watch those morning shows and they've got the coffee, are they really drinking coffee? Is it going to make their teeth brown, or is it like hot water?
Yeah.
Probably hot water, right? All right. So measles. Let's get into measles. All right. So RFK Jr. visits Texas after second child dies of measles amid outbreak. So Senator Bill Cassidy, a medical doctor, called on top health officials to unequivocally endorse measles vaccine before another child dies. So what we know is an 8-year-old girl, Daisy, same name as my oldest daughter. Daisy died in Texas on Saturday due to measles pulmonary failure. Now, Health Secretary Robert F. Kennedy Jr. said Sunday that the most effective way to prevent the spread of measles is the MMR vaccine. And this is his most direct statement yet on the issue following this death. Now, I didn't put in a link, and maybe I'll put it in next time. But unfortunately, there's a really disturbing article in The Atlantic where we find out behind the scenes, RFK actually went to that family, and though he publicly says this, he says to the family, we don't even know what's in that vaccine. And again, doubles down to this grieving family on his anti-vaccine, on his vaccine mistrust statements. And then when, people ask this organization, like, what's going on? And basically there's like, well, RFK is saying this publicly, but he's just lying to these, so just want to point out here, we have 2 children that have already died. And what is the response behind the scenes? RFK Jr. is undermining confidence in vaccines, attacking the doctors, claiming that the reason this girl died is she did not get this inhaled budesonide that they asked for, that they requested. Basically lying. We already have 2 children dead. This is not something that was happening before RFK Jr. stepped into this role.
Where is his medical degree from, Daniel?
He has no medical degree. And that's actually kind of scary. Here's a person, basically guiding people on medical decisions without any formal training. Never took an oath. The only oath he took was purely to himself. Bowman Army Hospital confirms a measles case at Fort Bliss. So we found out last Friday, it was April 4th, there was a measles case at the Mendoza Clinic at Fort Bliss. And from the CDC, and these are confirmed cases, right? So United States, total cases in the U.S. reported by noon Thursday, updated by Friday of last Friday. It'll be like a little week old when everyone hears it. But we are over 600 confirmed measles cases, all across the country, 22 jurisdictions. So Alaska, California, Colorado, Florida, Georgia, Kansas, Kentucky, Maryland, Michigan, Minnesota, New Jersey, New Mexico, New York City, New York State, Ohio, Oklahoma, Pennsylvania, Rhode Island, Tennessee, Texas, Vermont, and Washington. So we're up to almost half our states are seeing outbreaks. And I was even getting, an alert earlier today. We're starting to see outbreaks, around the world in places where we didn't really see them, in Thailand, Taiwan, places like that. So, and the main outbreak is really down there in Texas. So we got an update from the Texas Department of State Health. We're over 500 confirmed cases. 57 of those patients have been hospitalized. And one of the things I want to point out here is unvaccinated children grow up to be unvaccinated adults. And you can see here over 100 of these cases are in individuals over 18 years of age. And that's the problem because we think, and we'll talk a little bit about, one of these suffering, dying babies from a different disease. But we had an adult in New Mexico die. And that's unfortunately what happens is not only are children at risk, but adults are at risk. We also have an update from New Mexico where it's up to 56. And we will continue to share our vaccine recommendations. Remember, the MMR came out in 1971, and then for a number of years, folks were only getting 1 dose, so that's 68 to 89. Only 1 dose was recommended, so some folks there are going to need that extra dose. We always, I will keep in our show notes, just remember that this is an incredibly safe vaccine compared to the disease itself. Where we see 5% of cases with pneumonia, we see encephalitis. We're now seeing, these deaths in the children, and this is an incredibly safe, effective vaccine that does not cause autism. That's been looked at, that's been shown. If you want to go ahead and invent some fake science, it does not make it true.
And we do know exactly what's in the vaccine, contrary to what RFK Jr. says.
We know exactly what's in the vaccine. I mean, he's the head of HHS. If he doesn't know what's in the vaccine, there's a problem. He needs to look it up. He needs to ask. Just because you don't know, that just means that, you're not doing your job. Okay. That was back when he didn't know how many children had died of measles, right? Like, dude, this is your job. Okay. Maybe if I was doing a job that poorly, I would get fired. All right, pertussis. So 2 infants die of whooping cough in Louisiana as cases climb nationally. So the U.S. had more than 200,000 cases of whooping cough every year before the vaccine was introduced. 1948, the pertussis vaccine was widely used. The infection rates began to drop. But pertussis cases in Louisiana are rising just weeks after the State Department of Health said it was ending vaccine promotion. The state of Louisiana and Louisiana Department of Health have historically promoted vaccines for vaccine-preventable illnesses through parish health units, community health fairs, partnerships, and media campaigns. But no more of that. Surgeon General Dr. Ralph Abraham wrote in a memo, while we encourage each patient to discuss the risks and benefits of vaccination with their provider, LDH will no longer promote mass vaccination.
Well, what's the reason for that, Daniel? Is he an anti-vaxxer now?
It's political. It's political. I think we've said before, if you mix politics and science, you get politics. If you mix politics and medicine, you get dead children.
I'm not familiar with pertussis vaccines as I am with viral. So are there any serious side effects?
Well, I'm going to, a primer for you and our crowd. Let's talk
Very
about
good.
pertussis. So Bordetella pertussis, this is actually an infectious disease, a bacteria. So just a brief, and I'll leave in a link to the CDC webpage. So first, transmission. How do you get pertussis? So it's spread by those infectious respiratory particles. So it's transmitted by coughing, sneezing, sharing breathing space for extended periods of time. Incubation period is 7 to 10 days, but it can be like 6 days all the way out to 20. And the classic presentation is these paroxysms of coughing, an inspiratory whoop. So some people actually call it whooping cough, like whooping without the W instead of, and then the classic post-tussive vomiting. So you're just coughing to the point that you vomit. So it goes through this series of stages. So you start off with this, and they have, of course, these wonderful names, the catarrhal stage. And so this is that first 1 to 2 weeks with, it's a typical viral upper respiratory infection. You got cough, you've got coryza, which coryza is just a fancy name for like rhinitis, upper respiratory tract inflammation. Interesting is that fever tends to be uncommon. So this is kind of what seems like a mild viral illness, often no fever, but then the cough is gradually getting worse while the runny nose stays watery. And this lasts about 1 to 2 weeks with sort of this escalating. A lot of times people are not thinking about this unless it's escalating over time and that secretions are staying clear. Then after the first 2 weeks, this is when they go into this paroxysmal phase. And this is when the coughing get even worse, right? So it's been increasing over 1 to 2 weeks. Now it gets really severe. And now the sound of that cough is really distinctive. There probably are like AI programs for your phone, right? Where you just like put it on the phone, it tells you that's the whooping cough. Or a few of us who've been around long enough may actually recognize these long series of coughs between which there's little or no inspiratory effort. And the child going through this might gag, they might turn blue, they might be struggling to breathe. And this is really when you start seeing that post-cough vomiting. And this stage can actually last 2 to 8 weeks, can actually last for quite a while. And then if they survive, and most children will survive, then the cough can go on for over 100 days. So we affectionately call this the 100-day cough. Unfortunately, infants younger than 12 months of age who get pertussis, this can be quite severe. And I've got this picture of this little baby with a really severe case of pertussis. About a third of them end up in the hospital. So 1 in 3. This is really a horrible disease. And we're thinking 12 months of age. So some of these children are too young to get vaccinated. And it's even more common if they're under 6 months of age. One of the things we'll often see is that if mom did not get that pertussis vaccine during the last trimester, it can be particularly severe. And the unvaccinated or completely or incompletely vaccinated infants younger than a year have the highest risk of severe complications and death. About 68% can end up with this apnea where they stop breathing, and about 22% will end up with a pneumonia. So I want to point out this is another one of those vaccine preventable diseases. So we're not seeing children die of pertussis if they've got this vaccine. Also, I should point out it's not just children. I think I discussed a little while back that we had a young lady, middle-aged lady in her 40s, about 2.1 miles from my house who need not die, who died from pertussis. The case fatality rate for pertussis among infants younger than 6 months of age is 1%, 1 in 100. And what do? You get your vaccine. The pertussis vaccination is part of that Tdap or that Tdap. And so infants and children, the CDC recommends the DTaps. That's a big D, a big T, a little a, and a P, as acellular pertussis is in there. And it's a 5-dose series. So you start at 2 months, 4 months, 6 months. You get another 15 to 18, another at 4 to 6 years of age. So that's your 5. And then adolescents, we're recommending a booster at 11 to 12. And then there are some recommendations over time for adults. I've got a nice infographic in here. Adults, every 10 years, you should be getting updated. But there's a couple extra things we do. The pregnant women, they get a single dose of the Tdap during each pregnancy, preferably during that last trimester. And then what we've been encouraging now is get all the people who are going to be around your newborn to make sure they're updated so they don't give pertussis to your newborn. All right, so I'll leave in all the links there. All right, bird flu. Mexico reports first human case of H5N1 bird flu. The infection was confirmed on Tuesday in a 3-year-old girl living in the northern state of Durango. And as the time we're recording, she's hospitalized in serious condition. All right, human metapneumovirus. Just a brief mention of one of my favorite viruses, Vincent, the human metapneumovirus. And I've always described this, and so it's nice to actually see my observation, borne out in the data. The MMWR posted human metapneumovirus seasonality and co-circulation with respiratory syncytial virus in the United States, 2014 to 2024. And a really nice figure showing the pattern that I've talked about, whereas RSV and flu goes down, we start seeing cases of human metapneumovirus. And we know up here in the northeast part of the U.S. that spring is coming. It's time to get the sailboats back in the water. It's also worth noting that this is pretty solid right here. While RSV might rise to 10 to 15% range for weekly positive tests, human metapneumovirus is in the 7 to 10% as the RSV goes down. So I thought it was really interesting, right? So I'm over in Asia a few weeks back, and they're talking about, oh my gosh, we're seeing all this human metapneumovirus. And my first question was, when did you start testing for it? I bet you've been seeing lots of human metapneumovirus for years. You just didn't know. And a lot of people have no idea of how common this virus is. So we have, we've got flu, we've got COVID, we've got RSV, and we've got human metapneumovirus, really the big four. And this is one of the big four. And isn't it beautiful, the timing where you see RSV starts actually in the south, it moves up, and then the RSV season ends, and you get this nice blue human metapneumovirus peak. I know. Maybe you're not as excited about this figure as I am, Vincent.
I think it's really cool, but it just shows if you don't look, you're not going to find it. Right?
True, right? All right. And I wanted to, in line with the quotation, I'm going to talk a little bit about polio. Sort of put a human face on this, because I saw a gentleman, I was working last weekend and, busy covering different hospitals, and it's Sunday evening, and I got asked by the hospitalist, can you please see this gentleman? We have some concerns. So I go see this 74-year-old man. And I described a couple weeks back when I was a floating doctor seeing a woman down there in Panama, in remote Panama, who got polio as a child. So this 74-year-old man is a polio survivor. When he was 18 months of age, he was living in Tel Aviv. So he's born in 1951, so it's 1953. And he and his 3-year-old sister get polio. They get infected with the polio virus. They develop the disease polio, which has paralytic manifestations. He ends up with pretty significant disease, with significant paralysis of his arms and legs. Not complete, but to the point where he's not able to lift himself, get out of bed, anything like that. Now he's got a 3-year-old sister. She ends up in an iron lung, but they tell the parents, we expect her to do quite well. She's a little older. But unfortunately, she's in the iron lung, and she ends up with a cut in the back of her head, which I guess they did not see early enough. It progresses. she gets septic, so she dies. So now the sister dies. And he is left basically bedridden, right? So the parents have to lift him up, take him to and from to toilet him because he can't walk in any way. They end up coming to the U.S., and now he's 5 years old, and they see a doctor in New York City, right? You know, in New York City, doctor is very compassionate. They sit down with the parents, and they say, basically, nothing's going to happen here. You should just let him die and have other children. Parents are shocked. Like, oh my gosh. So fortunately, they ignored that doctor who has, well, I would say horrible bedside manner. And they continue to care for this child. They have some other children as well. And then finally, as an adolescent, he just says, I've got to get out of this bed. I'm not going to spend my life in a bed. So he ends up with braces on his legs. They make these crutches because he doesn't have the arms for the crutches. So they end up like under his armpits. And he's able to actually get around a little bit. He's able to actually go to school. He ends up getting a job. He actually does well enough. I believe he was an accountant, that he's actually able to take care of his parents when they get older. So, you know, he's able to get a job. He's able to be a productive member of society. Unfortunately, he is hobbling across the road on his crutches. He's had 4 rotator cuff surgeries at this point because he just keeps destroying his shoulders. And apparently he's not quick enough in his crossing of the road for the motorist, and he gets run down by a motorist. And now he's in the hospital with these horrible wounds that are not healing, and one in the backside is tracked into the sacrum. He's got this infection down into the bone, and now he's in his 70s, just still, suffering from this viral infection that he ended up as a child with the associated paralysis. So I just want to put a human face on this. Like, we talk about that boy that got polio in upstate New York. Now that boy is going to go on and, live a life like that. We've talked about all these other children throughout the world that are getting paralyzed by the vaccine-derived polio. And just to put a human face, this is not just numbers, not just statistics, but these are human beings that are suffering. All right, moving into flu. So to finish off that with I'm going to say some good news, right? I'm looking here at the 2024-2025 influenza seasonal week map, and it's like everywhere looks great except for New York and Maine, right? So really, like, activity is on the way down. New York's still like in the upper edge of high, and Maine is in middle high. So I don't know, but we're coming out. We're coming out of the woods. Looking at emergency department visits across the U.S., really coming down, kind of exiting the influenza season. But as we exit the influenza season, I want to point out too, and this get back to why would I consider vaccinating my child? Another 9 influenza-associated deaths were reported this past week. We're up to 168 children died of flu. And these are, vaccine preventable. 90%, as we say, 90% of people that die of flu did not get their vaccine. And as we know in children, half of these children who end up in the hospital, who end up dying of flu, were otherwise completely healthy before this happened. So these 168 children, most of those did not need to die. Get your flu vaccines. Okay, and RSV, also some good news here. Really looks like we're coming out of the RSV season, and it really was not that bad in RSV season this year. So maybe some of the stuff we're doing is having an impact. All right, COVID update. We're actually, by the WasterwaterScan, we're at medium. By the CDC, nationally, we're at low. And actually, things are looking pretty good, except for seem to be having some issues down in Tennessee and Alabama. We're actually seeing 2 to 4% of all deaths reported there last week were due to COVID. What I figured out, Vincent, is if you hover over the states, it tells you which state it is. So I don't have to remember that. That's why I know it's Alabama and not Mississippi. And our wonderful wastewater national trend, look at that. It looks just like the stock market. Look, it's crashing down. A few little bounces. That was a little blip, and then it came right back down, just like today. All right, so moving into ventilation transmission. And I have to say, this is a great study. This is a study I was waiting for, Vincent. Why did they not do this before? But here is the article. Human source SARS-CoV-2 aerosol transmission to remote sentinel hamsters, published in Open Forum Infectious Disease. So Here, these investigators used the South African Airborne Infections Research, the AIR facility near Pretoria, to study human-to-animal, H2A, I'm sure you need to acronym that, but transmission of SARS-CoV-2 in newly diagnosed patients. So the facility was actually built to study tuberculosis transmission, and this may remind some folks who think everything is about tuberculosis of those early hamster studies. But here they've got clinically confirmed COVID-19 patients housed for up to 4 days in the AIR facility with continuously exhausting patient ward air to hamsters housed in animal exposure rooms. After a 3-week exposure period, animals were held for an additional week to allow for antibody development. Animal serum was analyzed for anti-spike and plaque reduction activities and lung samples for pathology. 7 patients provided 400 plus in-resident hours over a 17-day period. Paired housed naive golden Syrian hamsters. 216 of them received continuous exposure to mixed patient ward exhaust. And serum analysis revealed anti-SARS-CoV-2 IgG in 58% of the animals tested. Plaque reduction assays on 7 high-titer sera revealed neutralizing activity. And as they comment, these results support the concept that viral bioaerosols generated from patients remain infectious over long-distance transport through a building ventilation system.
So that's why you like this, because it has to do with ventilation in a hospital, right?
It really does. I mean, so here's this whole issue about, we know that most of the infection risk, right, was like being right there within 6 feet. But what if it's, what if you've got, air coming out of that room, going into the other room? What if someone is across the hall, but you've got that ventilation? What we're seeing here is not just like PCR of the air samples, but we're actually seeing this functional assay where you've got a patient in the room and there's a ventilation system, and those infectious respiratory particles are ending up actually infecting these Syrian hamsters.
We did a paper on, I think, TWiV, where they did a study in a hospital where they fitted the ventilation systems with some kind of ionizing radiation, and it reduced hospital-acquired infections. So it seems to me that you could do this here in the HVAC system and inactivate those virus particles.
Yeah, there are actually, we sort of have this move in the U.S. Unfortunately, we have these grandfathered in buildings, but there's a move towards single occupancy rooms. Mm-hmm. And then you add to that this HEPA filtration or other ways of addressing, the infectious stuff that's coming out of the room. So, all right. And I'll leave in I got that nice image that maybe David can show where you can see the different, where the hamsters are and stuff. So. All right, COVID vaccination. I think we're getting to that time of year where some folks might be thinking about getting that second shot. So remember, per CDC recommendation, most folks it's a once a year, but for people ages 65 and older, talking about getting that second dose 6 months apart. Moving into the COVID early viral phase. Following the guidance, number 1, Paxlovid. It's actually interesting. Some of our local hospitals have been looking at maybe, if you end up in the hospital in that first week, it's not like suddenly something changes. So maybe looking at more Paxlovid use than always going to remdesivir, if that's appropriate. And this was, I think we talked about this last time, the cost-effectiveness analysis of nirmatrelvir or ritonavir for high-risk individuals with COVID-19, a modeling study published in Open Forum Infectious Disease. So, now that we're seeing less bang for the buck, so to speak, maybe the buck should be reduced for Paxlovid. Remdesivir, molnupiravir, convalescent plasma. And remember that second week, that early inflammatory phase, we're still seeing folks end up in the hospital. This is where we're looking at steroids on those folks with oxygen saturations less than 94%, anticoagulation, pulmonary support, and in some cases, remdesivir. And I'm going to wrap us up with 3 articles here in our long COVID section. The first article A little bit disappointing, but it's one of those things. If you do the science, then you got to live with it. And we did the science, and this is the article: nirmatrelvir ritonavir versus placebo ritonavir in individuals with long COVID in the USA, PAX-LC, a double-blind randomized placebo-controlled phase 2 decentralized trial published in the Lancet Infectious Disease. So this is the Yale study looking at Paxlovid for treatment of long COVID. And there's a number of authors in the list that a lot of folks might recognize. And given that viral persistence has been hypothesized as a potential cause of long COVID, these investigators looked at whether antiviral therapy might provide a therapeutic benefit. Phase 2, decentralized, double-blind, randomized controlled trial, adults aged 18 and over from 48 states across the contiguous U.S. with previous documented SARS-CoV-2 and long COVID symptoms, persisting for at least 12 weeks. Participants were randomly allocated to receive either the Paxlovid or placebo, and they're going to do that for 15 days. So between April 14, 2023, February 26, 2024, 119 patients were screened, 100 were assigned, 100 were enrolled, 49 assigned to Paxlovid, 51 to the placebo ritonavir group. They had 3 drop out in the Paxlovid group, 2 drop out in the placebo group. They found, unfortunately, that Paxlovid, nirmatrelvir ritonavir, administered for 15 days did not significantly impact health outcomes in participants with long COVID compared with placebo ritonavir at day 28.
Never was convinced that there was any viral persistence. It was just antigen or RNA, but this is consistent with that.
I think it's all in the details of the language. Like, so what they're thinking here is, maybe you can find some remnant protein, maybe some remnant RNA, but what they're really thinking is there's replicating virus, and if we interfere with that viral replication, people are going to get better. And we had the Stanford study that was negative. We have this study, it's negative. Unfortunately, I'm disappointed, but this is consistent, I think, with what we've been thinking, that no one in years have been able to isolate replicating virus in these individuals, and now we did 15 days of therapy and no benefit. So, all right, the article: quantitative brain volume differences between COVID-19 patients and non-COVID-19 volunteers, a systematic review published in the journal Neuroimage. Now, I was hoping for pictures of brains, right? But we just get lots of numbers in this review. Also, as they point out, the majority of the studies reported smaller gray matter volumes amongst COVID-19 patients compared to healthy volunteers. However, there were inconsistent findings, with 3 studies reporting larger gray matter volumes in the COVID-19 groups. Important context for these results is that studies with COVID-19 cohorts with more severe presentation, characterized by admission to the hospital or the ICU, were more likely to report smaller gray matter volumes compared to healthy volunteers, compared to patients who recovered at home. So, and it's not the entire brain. And I've got this nice figure where you look at different studies and you look at different areas of the brain where you might not see a difference, or where you actually see these differences. Like the hippocampus, most of the time you're not seeing a difference. The caudate, not much of a difference. But some other areas, like just the whole brain, as they talk about, the brainstem, for instance, that's a study, that's an area where you're actually seeing differences. So I'll leave that in there. And then the last, another sort of negative study, tried donepezil, Aricept. I'm going to call it Aricept. So donepezil for fatigue and psychological symptoms in post-COVID-19 condition, a randomized clinical trial published in JAMA Network Open. So these results are from a randomized clinical trial of 110 patients, baseline adjusted estimated treatment effect of Aricept, which is that minimally effective Alzheimer's drug, on fatigue. They saw a minimal impact, not statistically significant. Secondary outcomes such as depression, anxiety, quality of life, where they looked at 3 and 8 weeks, also negative. So nothing to see here. All right, now we'll wrap us up with as we've been saying for a while, no one is safe until everyone is safe. And there's a lot of folks out there who are less safe than they were a few months ago. We're trying to do everything we can with science communication, with getting knowledge to the people in places that need it the most, with supporting our sister organizations. And right now we're doing our Floating Doctors fundraiser, where for February, March, and April, we're going to double your donations up to a potential maximum donation of $20,000. A big exciting project down there in Panama is we're hoping to expand our point of care testing and even set up a little bit of a lab there, either at the base or in the local Bocas town. My daughter's going to Daisy's going to help out a little bit with that. We've got Julia Lebrat, and I was talking to Ben Lebrat just the other day. So we can only make this stuff happen with your support. So go to parasiteswithoutborders.com and click on that donate button.
It's time for your questions for Daniel. You can send them to daniel@microbe.tv. Rona writes, on the office hours of April 9th, that was last night, we had a discussion about the number of people who die every year from penicillin anaphylaxis. Someone said 500 to 1,000 people die in America every year. And Rona said, I thought that was too high. I looked it up, and that's what the internet says. The source is a 24-year-old paper in JAMA Network, JAMA Internal Medicine, that theorizes, based on allergy preference, you would see a 500 to 1,000 person annual incidence. It's a model and not an actual fact. So the question is, Dr. Griffin, do you know how many people die every year in America from penicillin anaphylaxis? Okay.
So this is actually, I'll say, an important topic for us in infectious disease, because so many people come in with this label of, I'm allergic to penicillin. I remember I was told by my mother I was allergic to penicillin. And then I reached a certain age where I began to realize, dare I say this, that not everything she told me was true. And I decided that this was actually maybe one of those things. I went ahead, took a 500 milligram amoxicillin, and I was absolutely fine. I am not penicillin allergic. Now, as you point out, this stuff is still in there. American Academy of Allergy Immunology, they've got stuff in there. But if you actually go back and look through the literature, a lot of it is people referencing stuff, and then you look at the references, and it's not really even in the references, it's just modeling. So there was a really nice publication in the UK where they looked, it was like 100 million amoxicillin exposures, right? Because a lot of folks get amoxicillin before they have dental work. So they look at 100 million exposures. There was one death in 100 million exposures. So this number of 500 to 1,000 anaphylactic deaths from penicillin each year in the U.S., it's not accurate. It's inflated, and I think it feeds into this this fear of giving penicillin. And what's really critical from a stewardship point of view is delabeling people as from this penicillin allergic when they're not really. Hospital is a great opportunity to go through the process and hopefully find that a person is not penicillin allergic. Put in context, it's not 500 to 1,000 a year. That's based upon bad data that's been recycled for decades.
Ellen writes, here in Asheville, the few places that did carry Novavax, Publix, CVS, ran out and didn't reorder. The one at CVS expired March 31st. Why do they, the famous they, seem to be slow walking or underprivileging Novavax? Is the small uptake of boosters across the board going to affect the availability of any COVID vaccine? So let's take that one first. Dan.
Yeah, let's take this first. So I am really disappointed with what happened with Novavax, right? It was sort of we always talked about when they were doing the vaccine, all the eggs in one basket, the spike basket. So that's fine that all the eggs were in one basket with regard to the antigen. But then so many of the eggs in the U.S. were in the mRNA vaccine basket. And there were a lot of people who have, anti-vax or vaccine concerns and I'll say that, vaccine concerns, that's fine. You don't have to be an anti-vaxxer to have questions about mRNA and maybe want a more traditional protein-based alternative. But unfortunately, we never really helped Novavax, which was struggling with production, manufacturing, quality issues, and the rest. And so we ended up with this company almost going under, ended up having to have someone come in to kind of help them. They've never gotten full FDA approval. So that's one thing. I am concerned about the future of Novavax, the future of this as an option, and whether or not it's even going to be available as an option this spring for a lot of people that may want to do this as their booster. The other, I think, is the bigger question, is that if we have really small uptake of boosters, there's a certain point when, are they really going to be even available every year? And as we've talked about, the bang for the buck was that first series. But there's another, particularly in the high-risk individuals who may end up in the hospital, a 40 to 50% reduction in medically attended COVID, 40 to 50% reduction in ending up in the hospital. So, really looking particularly at people in those risk groups, it really will be a disaster if they don't have access to the vaccines.
Other question is, my daughter was born in 1984. I don't recall if she had measles. Would she have gotten the single vaccine? Should she get a booster just in case?
Yeah, so she was born in that zone, right, when up into 89, when they were only recommending one shot. So she may not have got that second shot. So, folks that are in that, and we leave in that link to the NYP recommendations, and the recommendations that people who are in that period of time up to 89, it's like 68 to 89, but you can look at the chart. That's when only one shot was recommended. So 71 to 89 was the MMR. May have only gotten one shot, so the recommendation would go ahead and get that second MMR vaccination.
Chuck wants to know, why can't we just add H5N1 to the current flu vaccine? It's already got a bunch of strains in it.
It's an interesting, we don't have a licensed vaccine that matches the current circulating H5N1. This is this big discussion every year about what's going to go in there. It really hasn't reached the risk to human health level where this is being discussed as being put in the yearly flu vaccine. Vincent, you have any thoughts other than that?
I remember back in 1976. There was a swine flu outbreak in Fort Dix, a couple of cases, and they decided to immunize everybody in the U.S. against it, and it never went anywhere.
Yeah.
And instead, many people got Guillain-Barré, about 400 people got. Do you remember that, Daniel?
Oh, I remember that. Was that under Ford? Who was the president?
That was under Gerald Ford.
Yeah,
yes.
Gerald Ford. Yeah, I was alive.
So you have to wait until it emerges.
Is this before or after our most athletic president fell down the stairs getting off the airplane? Right. Here's a guy who's like, what was he, a college football star? He's
he was. Yeah.
And he's the one we remember as like tripping down the stairs.
Yep. Casey writes, my mother is a non-responder to measles vaccine. I've had a full course, but I never checked my response. Should I look into it? Is it hereditary?
I don't know. That's a great question. And I think as we've tried to point out, people say non-responder because they get the measles vaccine and then the antibodies don't go up. But we're not sure, particularly think about how long-lived this is and the whole incubation, everything about measles. Like how much of the response is T cells? And we're not checking the T cells. When we say you're a non-responder, I don't know if you're really a non-responder. You might just be someone who doesn't have antibody titers.
P.S. The bow ties really make some of the more disheartening updates a lot easier to handle.
I'll keep wearing them.
All right. Marie writes, it's a story. I was a little shocked today. I went to a CVS to get my COVID vaccine. I mentioned about the measles outbreak. The pharmacist, who's been working there for 26 years, surprised me. He said, it's just the news cycle. We're making a big deal. We've always had measles outbreaks. We used to have measles party. I was disturbed by his reply. I wanted to confront him. There are 600 cases of measles in Ontario. It can wipe out your immune memory. And then I just left the store. It wasn't worth getting into it. I was going to recommend your podcast, but I knew he wouldn't listen. I really appreciate all you do.
Yeah, no, this is tough. And, Marie, it's, I have to say, I feel like it's a failure on our part. And hopefully Vincent and I and the crew at Micro TV are trying to correct this with science communication. A lot of people get their medical information, their science information from whatever mainstream media they choose, whatever social media they sort of funnel to themselves. And unfortunately, because of that phenomenon, we have a lot of folks that have a view like this. They don't realize that we had hundreds of children dying a year before we had the measles vaccine. I don't even think people realize that we had hundreds of children dying a year from chickenpox before we had the chickenpox vaccine. I definitely hear that. So, unfortunately, I think we have to do a better job of educating everyone. And unfortunately, again, it's not numbers. You can't just say, oh, hundreds of children. You need to actually start telling the stories of those children. For instance, like that young girl, Daisy, who just died in Texas.
Yeah, unfortunately, her father is still anti-vax despite her death. Failure to communicate.
Yep, that is what we have here.
That's TWiV Weekly Clinical Update with Dr. Daniel Griffin. Thank you, Daniel.
Thank you, and everyone be safe.
What we have here
is a failure to communicate.